Hello, everyone. Thank you so much for joining us tonight. It looks like people are still joining us, so we'll give everyone a couple more minutes and then we'll get started.
Okay, got a few more folks joining. Dr. Billings, I just wanted to check your sound really quickly, make sure your mic's working.
Sure. How you doing?
Wonderful, perfect. Sorry for any confusion. And Deborah, you as
Okay.
well?
Yeah, can you hear me okay?
Perfect, awesome.
All right, then let's go ahead and get started. Hi, everybody. Welcome to our panel discussion on becoming an anesthesiologist-scientist. This is an exciting collaboration between the Foundation for Anesthesia Education and Research and the American Physician-Scientists Association. Thank you all for joining us for this event. My name is Cynthia Tang. I am the past president of APSA and MD-PhD student at the University of North Carolina. I'll be moderating the session today with Deborah Rupert, APSA's resident fellow, member at large, and anesthesiology resident in the Academic Scholars Advancement Program at Washington University. We are joined by leaders in the field who will be sharing their experience and advice for physician scientist careers in anesthesiology.
Before we get started introducing our speakers, I just want to give a brief overview of how the session will run tonight. So we're going to begin with a presentation from Dr. Kelz, who is the president and chief scientific officer of FAER, and he's going to be able to speak a little bit about the options for anesthesia research training, specifically residency training. And then following his presentation, we will be able to hear from each of our speakers on the panel who hopefully will give us a little bit of insight into their own career trajectories as outstanding physician scientists. And then we will have a live question and answer. I know some folks had submitted questions ahead of time, so we'll do our best to get to those, but please feel free to use the chat, and we're hoping to have good interaction between our panelists and the audience. And thank you everyone so much for being here.
And I will now take the opportunity to briefly introduce our speakers. One of our speakers is Dr. Charles Emala, the Vice Chair for Research and Director of the Apgar Scholars Program at Columbia University. Dr. Mark Bicket, Co-Director of the Overdose Prevention Engagement Network at the University of Michigan, and he'll also be able to provide insights on the Clinician-Scientist Translational Anesthesia Research, or C-STAR program. Dr. Josh Billings, the Director of the B.H. Robbins Scholar Program at Vanderbilt University, and Dr. Max Kelz, the Director of Research Education and Vice Chair of Research at the University of Pennsylvania, and he'll also be able to provide insights on the DRIP Fellowship. Dr. Kelz is also the President and CSO of FAER, and he will now provide us with an overview of physician scientist training opportunities in anesthesiology.
Well, first of all, thank you for inviting me. I'll pull up my slides and just tell you how excited I am to be here. And let me launch my talk. Okay, hopefully you can see my slide. So I thought I would talk about very briefly the pathway to becoming a physician scientist in anesthesiology, and I decided I would expand it to cover anesthesiology's core and related disciplines of critical care and pain medicine. And you've already heard about our three outstanding speakers, so I'm going to let them talk for themselves, but we're very lucky to have Dr. Billings, Bicket, and Emala as part of the panel. I thought I would tell you very briefly about my own journey that was facilitated by FAER down the path towards the clinician-scientist in my practice. And to do that, I figured I'd take you in the Wayback Machine to last century when I was a medical student. So I knew I wanted a career in neuroscience and a career in medicine, although I wasn't quite sure of my specialty. So I did the MD PhD training. I got fascinated by the question of how change in a single gene in the brain could alter something like a behavior. And after going through the traditional 2 years of med school and 6 months on the wards, I transitioned into the PhD phase. And I was fortunate enough to work with Eric Nestler, who is a clinician-scientist in psychiatry. I alluded to the fact that this question of how genes change behavior was something that thrilled me as an undergraduate. And I was lucky enough to be in Eric's lab, both as an undergraduate and a graduate student. I had found that repeated but not acute exposure to drugs of abuse like cocaine or opioids turned on the expression of a novel transcription factor. And my PhD project was really to try and understand what that transcription factor did. And so my training was really in mouse genetics. And we were amongst the first that I know of in the world to use tissue-specific inducible gene expression system in mice. I got very lucky in that I turned on this transcription factor in a mesolimbic dopamine reward circuit and wound up genetically engineering a mouse that was predisposed to drug addiction. Now, you may think, how do you study psychiatry in mice? And this was a problem that we wrestled with. So Eric was very clever to carve out a role for craving and addiction. I wasn't quite sure how my career would translate. I went back onto the wards after a successful PhD, hadn't really considered anesthesiology as a discipline. And I wound up doing a rotation right after my return to med school. I was fortunate enough to be allowed to place a labor epidural in a pregnant patient. And the ability to knock out pain in a woman who was so clearly suffering was just an instrumental moment in shaping my career. It opened my eyes to the idea of anesthesiology as a clinical discipline, and really got me hooked. So I applied to residency in anesthesiology. I did an early precursor to the research track residencies that I'll tell you more about. FAER turned out to be very instrumental in my early career. As a resident, I applied to their mentored research training grant, which I'll speak about momentarily, and launched my career actually not in the way I thought when I was applying as a medical student, where I reasoned I would probably become a pain researcher, but rather I was shaped by a case that I had during residency that I'll tell you about in a moment. And if I could leave you with one lasting point, it is the critical importance of foundation funding to help launch. And so anesthesiology is lucky to have both FAER, the Foundation for Anesthesia Education and Research, as well as the International Anesthesia Research Society. Both groups offer funding to clinician scientists interested in developing careers. So I'll tell you very quickly about the case that shaped my career. When I was a resident, I would commonly hear my attendings tell a patient that we were going to put them to sleep. And of course, inwardly, I'd sort of laugh at the idea that sleep was just a convenient metaphor that sounded a lot more comforting to patients than telling them we were going to put them into a chemical coma that we thought we could reverse. And then as a first-year anesthesia resident, I had a case very similar to the one described in this report of a patient with narcolepsy and cataplexy who had very prolonged times to exit the state of anesthesia. In this case report, you see an individual who took 8, 9, and 10 hours to exit an anesthetic state compared to the more typical 8 to 10 minutes it takes to come out of an anesthetic state. And in my case, my narcoleptic patient took more than 6 hours to regain consciousness after a very straightforward general anesthetic. It turns out that narcolepsy is a primary disorder in the organization of sleep and wakefulness. And this thought that that there might be some synergistic overlap between how the brain regulates states of sleep and arousal and where and how anesthetics work convinced me that anesthesiologists should really try and understand more about regulation of states in the brain. And so armed with that as a resident, I returned to that early thought about mouse models for behavior. But instead of going down that psychiatry pathway, I realized we had a very easy assay in anesthesiology to tell when animals were conscious versus unconscious. And that, more than anything, is the assay that, with FAER funding, helped me launch my career. And so over the last 20 years, I've been interested in the neuroscientific control of how the brain enters and exits states of anesthetic-induced unconsciousness and the natural barriers that prevent inappropriate state transitions. So I've told you that I trained as a mouse geneticist. Being a physician scientist offers special opportunities to translate findings in animals. And in fact, we did that. The first translation I wound up doing early in career was actually backwards down the evolutionary ladder, thinking about work in fruit flies and subsequently in zebrafish. But ultimately, our studies have even encompassed looking at how humans transition into and out of states of unconsciousness. So that's a little bit about my background, and what I thought I would do next in the remaining 5 minutes or so is tell you more about the pathway that many of us have chosen as we become physician scientists in anesthesiology, critical care, and/or pain medicine. So the other point I'd like to leave you with is, as you become more interested in anesthesiology as a potential clinical specialty and as a great home for physician scientists, I would refer you to the Early Stage Anesthesia Scholars website. That website is listed on the bottom right of this slide. It's a group that has curated, a group, I should say, of medical students, residents, fellows, and early career junior faculty that have curated probably the latest information on how to become a physician scientist in anesthesiology, how to be engaged in research. You'll see on this map of the US the roughly 24 or so programs in anesthesiology that offer specific research and residency options. These typically range anywhere from 6 months up to about 11 months during the traditional 4-year anesthesia residency training. And then most of these programs, they come in different flavors. You'll hear more about those subsequently, but most of them will build in a 1 or 2 year fellowship where our anesthesiology residents will function. Typically, it's 80% of the time as a postdoc, bringing up their scientific training while ensuring that their clinical skills they work so hard to gain during residency don't atrophy. And so during 20% of the time, most programs across the country will have that resident scholar function as an attending during the 1 or 2 years of fellowship training. Most of the way that we do that for programs around the country is to incorporate an NIH-funded T32 training grant. And you'll see that the majority of our research and residency programs have a T32 as part of the department makeup. The data I've shown here may not be complete. I pulled it from NIH Reporter about 2 months ago. And I know the reporter has some issues. It won't find funding in places like the Mayo Clinic, or if you don't look at Harvard, they don't come up as single institutions. So this list may not be comprehensive, but it should give you a flavor. And I think the main reason for my invitation tonight is to talk a little bit more about how FAER can help you on your journey as an aspiring clinician scientist. So FAER is the foundation for anesthesia education and research. And our sole mission is really to help launch the next generation of clinician investigators in the specialty of anesthesiology, critical care, and pain medicine. And how do we do that? We offer grant funding that's staged throughout the career. So we go as early into the pipeline as medical school. We have opportunities to do research for our medical student anesthesia research fellowship, which is an 8-week program that's commonly taken up by either medical students between their first and second year. They'll spend a summer working in an anesthesia lab that could either be at their home institution or at any program in the US. The other point where we'll see our MSAR fellows jump into the pipeline is oftentimes after core rotations end, either in the third or fourth year. So there is no preset requirement to do the MSAR fellowship as a rising second year med student. FAER is happy to accept students according to the requirements at their home institution. The only thing that we ask is that our MSAR fellows have an uninterrupted 8 weeks to spend, and they're paid to do research and see what it's like to do clinical anesthesia. Usually that's 1 day a week. We offer opportunities for residents to present research, whether they're in a formal research and residency program or not. And typically our RSP is a program where FAER will pay for medical students to come to anesthesiology's annual meeting at our celebration for research, which is every Sunday of the ASA meeting. And that's a great opportunity to bring together the research community in the specialty. We have opportunities that are FAER funded for anesthesia residents or fellows to take a year and do research, and that's our RFG grant. I'll point out we've developed a couple of new programs over the last year. So Dr. Bicket may talk about the Advanced Medical Student Subsequent Research Fellowship, which offers up to a year of paid time in medical school to do pure research in an anesthesia-related area. We've also launched a new program for MD PhDs specifically that's similar to our Resident Scholars Program. In this opportunity, MD PhD students can apply to FAER to get paid travel to go to anesthesiology and present their PhD graduate work in that day for new researchers, which is the Sunday of the annual anesthesiology meeting. Now, FAER has opportunities to fund education grants, and we do a couple of different research and education grants. These can be applied for at any time during the career, including junior faculty all the way up through senior faculty. And I suppose there are options even to have those earlier in career. What you'll see with our research and education or REG grants are that we form partnerships. So FAER funds some, and we have a partnered grant opportunity with the American Board of Anesthesiologists or the ABA to fund research questions in education. Our signature grant offering is really the Mentored Research Training Grant. It is a 2-year opportunity that really functions as a pre-NIH-K grant. For our MRTG grants, we award for the first time up to $300,000 that's given out over 2 years. Our MRTG fellows will spend a minimum of 60% time doing research and a maximum of 40% time doing clinical service as they spend 2 years working to launch as independent or on the pathway to launching their academic careers and ultimately towards independent funding. The other opportunity I'd like to highlight is a new grant program where FAER is partnered with the National Academy of Medicine. And this is a program to provide early career anesthesia scholars the opportunity to participate in committees, workshops, and roundtables with the National Academies of Science, Engineering, and Medicine. And the purpose is really to provide our FAER NAM fellows the opportunity to participate in evidence-based healthcare or public health studies that expand beyond the traditional boundaries of anesthesiology. And our inaugural FAER NAM fellow is Julie Freed. There'll be additional opportunities to join this program, which is offered every 2 years. So with that sort of brief introduction to FAER and our funding portfolio, I think I'll stop sharing and I'll turn it over to our distinguished panelists. And I think, Josh, maybe you are the next to go.
Sure. Thanks so much for the introduction, Max. And I'm also very happy to be here and joining you all remotely for this APSA and FAER session. Yeah, I think I've been asked to just kind of give a little bit of a history of kind of how I personally developed interest in both anesthesiology, perioperative medicine, and research, within those fields, and kind of what my own path looked like. And I think from an APSA standpoint, a lot of the APSA members really have an earlier idea that research is important to them and discovery. It's become very important to me, but I kind of came onto it a little bit later. I was always very project oriented, and I like designing things, and I like completing things and kind of finishing something and having a product for my labors and something that is kind of a building block for the next step. So I kind of been like that since I was a little kid. But I didn't really know that I wanted to do research and discovery, which those interests align with so well. During medical school, I was enamored with physiology and pharmacology of anesthesiology. I liked the quick action of treatment paradigms and managing things on the fly. I liked all the monitoring, all the technology, and just kind of the energy involved in the perioperative space, both in the ICU and in the operating room. So that drew me towards anesthesiology. I always kind of did a little bit of a pet project here and there, but it wasn't until fellowship. And I would say, so I was a medical student at LSU in Louisiana. I grew up in Louisiana. I was a resident at Vanderbilt, and then I was a fellow in cardiothoracic anesthesiology and critical care medicine, both at Columbia. And it wasn't until that point that I really had a taste of some real research, and I was hooked. The fellowships out of anesthesiology, the clinical fellowships, are only a year each, which is different from surgical fellowships, pediatric fellowships, medicine fellowships. And they don't have a lot of built-in research opportunity. And so that's why a number of the panelists here tonight were actually part of physician scientist development groups within our departments that try to provide opportunities for trainees. So for example, if you're a pulmonology fellowship, you're not getting you're not getting 2 years your mandatory research, whether you want to do research or not. So that really didn't exist within anesthesiology. So we have worked hard to build programs that provide opportunities like that. And so as a fellow, I thought, well, I do have 5 months of elective time during my 2 years. And so I dedicated that to a single project and joined the lab of H.T. Lee, who's a phenomenal anesthesiologist and I think maybe even more so an investigator. And we, from day one, we're generating data and performing experiments, looking at a mouse model of radiocontrast nephropathy and the action of alpha-2 agonists within that model, and studying mechanisms of AKI. And I was hooked in a way that I thought, okay, this is highly translational. I can work on projects while also maintaining clinical balance. I love the variety of bouncing back and forth. And I'm looking at a disease, acute kidney injury, which is quite common in cardiothoracic anesthesia patients and as well as in the ICU. So that was kind of a common theme that allowed me to kind of like tie it all together. And still today, I'm bouncing back and forth between ICU, OR, lab, but with that common theme that kind of holds it all together. So I don't feel like I'm really wearing 3 hats, so to speak. I always tell our applicants to our residency or our B.H. Robbins Scholars Program or to fellowships, or that within anesthesiology, I really feel like you can have your cake and eat it too, so to speak. I think you can get some of the best benefits of a highly productive and demanding clinical career with all of the perks of a career in research. Some of those being time management, come and go as you please, setting your own clock, setting your own pace. That is a luxury that a lot of people, I don't think, put enough stock into earlier in their career. As an anesthesiologist, even today, I was in the OR. I wasn't handed a piece of paper. I mean, it was virtual. I said, here are your cases, go for it. And it was great. And it was, I mean, we did some, in fact, I shocked a lady out of ventricular tachycardia in the prone position who was rebuilding her hip from an automobile accident, who had had a ventricular assist device placed 6 months previously. I mean, that is a pretty crazy experience. And so, I mean, I think there's a lot of value there. At the same time, we were in the lab performing some experiments on an AKI model with mice, some of the people in the group. So I do feel like you can have your cake and eat it too. You can take a skill set and really run anywhere with it. Physiology and pharmacology, I think, being kind of the hallmarks, like Dr. Kelz mentioned, having witnessing a case that really prompted him to explore the physiology in the brain in a situation like that with a prolonged emergence. So like anything, it's a journey. And I think that, I kind of found my passion within anesthesiology and doing research within it. And if you like kind of the project-based approach to your career, and some of the perks that anesthesiology may contain, I think it's an excellent opportunity to explore numerous different types of pathology, because so many patients come through the doors needing procedures, needing sedation, and they're there in times of critical illness or demise, and that's where those are the types of diseases and patients that need the most research. So it's really a fantastic opportunity when you kind of stand back and look at it from kind of a 30,000-foot view. I think I'll pause there.
Fantastic stuff. Dr. Emala, would you like to go next?
Sure, thanks. It's fun to join my friends on the panel, and I really want to thank APSA for organizing this, and we would love to do more of this going forward. So please keep the programming going. It's been a real pleasure of mine to participate in the annual meeting of APSA in Chicago for the last few years, and also the New York Regional Society of APSA as well. So we're passionate about what we do, and we're passionate about helping to fill the next generation of physician scientists. So opportunities like this, we won't pass up. So I'm the Vice Chair for Research at Columbia University. I've been there for more years than I'd like to admit. I'm also honored to serve on the FAER Board of Directors. So I see Dr. Kelz at least weekly. And we do this solely out of a passion for sort of passing on the benefit that we've had in our career to what we realize to be the next generation of physician scientists. I also direct a program at Columbia referred to as the Apgar Scholars Plan, and you're going to hear from each of the individuals tonight that each department represented tonight has sort of a research track built within their residency, and there are a few dozen of those, and Dr. Kelz alluded to the ESAS website that has a very nice Excel spreadsheet of some of those programs. I also am the PI on a T32 program, of which there are about 18 across the country in anesthesiology. So my story is kind of totally inspired by mentors. So prior to medical school, I did a master's degree in microbiology, loved being in a wet lab, loved doing experiments at the bench, but really saw myself as a clinician and went to medical school assuming I was kind of done with research. And as much as I enjoyed it, I really saw myself being a clinical physician full time. And fell in love, I think, with the specialty during medical school, during my exposures to surgery, where I realized that what was happening on the other side of the curtain seemed really interesting. Unfortunately, where I went to medical school at University of Maryland, we didn't even have a required exposure to anesthesiology, which is very common across the country. So many of us discovered anesthesiology while we were on other clinical rotations, whether it's surgery, obstetrics, and what have you. And I realized that in medical school, much like the previous speaker, physiology and pharmacology was what medicine was to me. I always loved to know how things worked, including human physiology. And then to think you could manipulate that acutely with pharmacology was fascinating. So it was pretty clear to me by late third year of medical school that I wanted to be an anesthesiologist. I still saw myself headed for clinical medicine. I saw myself out in the community practicing clinical anesthesiology, but I was fortunate enough to train in a residency program that was infectious with the idea of new discovery. I was fortunate enough to train at Johns Hopkins, which had really a robust culture of discovery and ample opportunities for individuals to get involved in research through incredible mentors. And if I give you one piece of advice tonight, it's find that special mentor that will make all the difference in your career. And I was lucky enough to find that special mentor, even though I didn't realize it at the time. And this person introduced me to whole animal physiology, looking at asthma actually in a dog model. And she was very interested in how anesthetics were bronchodilators and understanding a little bit more why. And I started the first 6 months or so in the lab, putting dogs to sleep, intubating and measuring airway resistance and waking them up again. And she realized that whole animal physiology was a good start, but that I probably needed more basic science training, and sent me out for 3 years to an endocrinologist lab, where I became very well versed in molecular biology, learned how to do Western blots and Northern blots, which we don't do anymore, Southern blots, which we don't do anymore, PCR, et cetera, and a lot of biochemical assays. And then came back and was able to apply a lot of those more basic techniques to understanding airway smooth muscle physiology in the context of asthma. So my entire career, I've been very interested in identifying novel ways to relax smooth muscle, particularly in the lung, in response to an asthmatic attack. And our lab has been successful in a number of directions of not only identifying novel compounds for that, some of which have led to company startups, but also compounds that simultaneously reduce lung inflammation, which is a key component of asthma. And as the years went on, I have to honestly say that the most fulfilling part of being a physician scientist is then starting to mentor the next generation. So I've been in a department both at Hopkins and now at Columbia that have been very supportive of supporting residents, fellows, junior faculty on their career paths as physician scientists. And I've been blessed to be allowed to be a mentor for some of these individuals. And, you know, when you come into the lab in the morning and one of the people around you is a lot smarter than you, hands you a paper and says, we've been doing all this wrong. Here's the direction we should take. It's really inspirational. And that's really been the most fulfilling part, is to contribute to the careers of the next generation. So although I still run a basic science lab and so have NIH funding for my lab, my most excitement is when my mentees get their own grants and move on in the pipeline. Max mentioned a host of funding opportunities that FAER provides. We're very fortunate actually in our specialty to have the FAER Foundation and a few other foundations that offer early stage funding. Max mentioned all the way from medical student up through junior faculty years. That's not present in all specialties, and it's a real I think kudos to the specialty that they have invested in those career development paths. So I'll wrap it up there. I just want to say that all of us on this panel would be more than happy to talk in the future. I put my email in the chat. I'm sure my colleagues will. I enjoy having a one-on-one Zoom with medical students and people thinking about residency and career paths to talk about opportunities around the country and so forth. So I just encourage everybody on the webinar tonight to have a very low threshold to reach out to any of us for more discussion and more details. So I'll pause there.
Wonderful. Thank you so much. Dr. Bicket, I think you have the floor.
Great. Thank you so much for the invitation to join this very esteemed panel. I'm fortunate to be probably the junior member here, and it's quite a esteemed group that you've heard from so far. So I'll try my best to live up to the standard here and just share a little bit about my story for coming in to the kind of scientist phase as a clinician investigator and someone who's focusing a lot of their work on pain medicine and anesthesiology outcomes. So, similar occurrence that you may have heard before, if you're here at this talk, you're well ahead of the curve when I was at probably almost everyone's stages of their career, perhaps with the exception of some early career faculty members who may be tuning in. I'd engaged a little bit in some different scholarly work. I did my medical school training at Johns Hopkins and enjoyed time with mentors there, and was having some thoughts about different specialties. My father actually was a practicing anesthesiologist, and when I came through, my goal was to make sure I didn't just go into the specialty because I saw him do it. And so I did everything else and then went and did my anesthesia rotation, and just it clicked very well. It was a little bit of procedural aspect, some internal medicine thinking, blended some aspects of psychiatry when it came to thinking about pharmacology and the drugs that we use. You heard earlier from Dr. Kelz's presentation, some of this aspects about the intersection of consciousness and what that state means. So we can get pretty metaphysical pretty fast, but there's also just the day-to-day realities of putting someone to sleep, keeping them safe, the teamwork-oriented culture, safety, focus, all these things just seemed like a culture that I wanted to be part of. And what I came to learn during my clinical training also seemed that, I could have a career in which I would never be bored clinically, because in essence, I can access and have clinical encounters with patients of all age ranges, of all backgrounds, in almost any setting. And that's pretty powerful when you match that with interests about scientific inquiry. And so while I'm speaking to you as a pain medicine physician, anesthesiologist physician, really it's hard for me to imagine a line of research that anesthesiology couldn't support as a career. And that diversity can certainly help line up if the specialty ends up being a great fit, as well as, if for some reason, one group ends up not necessarily being the right focus for your career within the specialty, it's not too difficult to vary clinical locations. So, yesterday I was in the fertility clinic giving anesthesia, and then I'll also be in our pain clinic seeing people in an outpatient setting, and then around in the hospital on the epidural and catheter service. And so just a variety of settings is really nice to do. When it came to thinking about a career in research, I have to say this came on a little bit later on the side for me. And I did think about doing a similar program at Hopkins that was like the C-STAR program that we have at the University of Michigan. This is where we have dedicated time. You've heard, I think, some of the panelists mention that the clinical training in anesthesiology is 4 years. And this is typically including a transitional year, base year, and then 3 years of clinical anesthesia. That time period, 4 years sounds obviously like a lot, but it goes by very fast. And I found myself when I was kind of as a clinical anesthesia year 1, which is typically a PGY2, and then going into my second year of anesthesia training, CA2 year, thinking, wow, this is going to go by so fast. And if I'm going to have a research career after this or academic career, I'm going to miss the exposure to these clinical options. And those include exciting things like liver transplant. I don't do that anymore, but I certainly wanted to get my load of cases in as a resident. Cardiac anesthesiology, if I didn't do pain medicine, I might have done that. And I wanted to make sure I had adequate exposure to that. So later on, I could at least be informed about what that was like. And so I actually made the decision to not apply through that program at my own institution in lieu of continuing on with my clinical training, because I felt like it was going to pull some of my time away, and I actually really wanted that exposure. So I did a pain medicine fellowship, and during that time, at the end of residency and through fellowship, had worked with mentors. You've heard that as a strong theme here. We started doing systematic reviews, and I didn't know much about methodology, but spent a lot of time reading and learning, and soon realized that I needed actually formal training in this. And so had started understanding the role that would help if I at least started out with a master's degree or considered a PhD afterwards. And so after a clinical pain fellowship, came back to Hopkins and did a T32 program and enrolled in a master's program at the School of Public Health to gain research skills, which is how their program was oriented for early stage faculty. And after doing some time in that program, quickly realized that I was probably going to publish. I wanted to have an academic career, and it made a lot of sense for me to adjust my course load and switch into a PhD program. So it was applied at the School of Public Health. It focused on pharmacoepidemiology, so the study of drugs as they're viewed through a lot through claims data or other large big data sources, a lot of building blocks with biostatistics and epidemiology. And then the other half of my program focused on clinical trials. So these could be phase 1 up through phase 4 or post-marketing studies. And so the balance of my career has largely been related towards developing studies about the safety of opioid prescriptions, given the hallmark of the opioid crisis when I was coming through training was prescription opioids, but we've seen the crisis switch and emerge in different ways. And this integration of pain medicine with opioids has been a big focus of that work and drives a lot of the work I do today. After the T32, I was lucky enough to be one of those recipients back in 2016 or 2017 for the FAER MRTG program that you heard Dr. Kelz talk about, and certainly indebted to that. The ideal is for people to transition from that program over to the K, and I have to tell you, in all honesty, I failed at that several times and continued to fail and actually never got the K award, but somehow miraculously was able to secure funding later on after that. And so can certainly share that story later time, but just want to let people know that, you know, if you do happen to fail at a transition, it doesn't mean that the game's over or that somehow it's a reflection on you. It's a competitive environment out there, and that's okay. You heard Chaz talk about mentors. I mean, we had a lot of conversations with mentors about, you know, what to do, how to approach this. And I think the idea was, you know, keep answering important questions, keep doing the good work and working with the teams that you have and doing what you can to get through there. So really appreciative for that effort. On the flip side now, I do spend a lot of my time mentoring students. Dr. Kelz mentioned about this advanced medical student program. And so I was very fortunate to be able to work with a great medical student a couple of years ago who had a very strong interest in applying for that program. And so she's going to start in July as one of the 2 recipients of that, and I'll be able to mentor her. And so certainly really looking forward to that. So at the end of the day, I know we have a lot of questions and more discussion, but certainly the diversity within the field. We haven't even talked about a lot of like the teamwork, systems-based thinking, other applications I think that come in beyond in the clinical realm and as a very rich environment for clinically oriented research, which may be a little bit different path than perhaps that in basic science, but one to consider as well out there. So again, thanks for your time and looking forward to chatting with the panel.
Thank you so much to all of our panelists. We'll now move into our live Q&A session. Please feel free to unmute or send your questions through the chat, and I'll go ahead and get us started with one of our pre-submitted questions. Do you expect anesthesia to continue increasing in competitiveness? And what is your ideal research residency candidate?
I'm happy to take the first part of that. Anesthesiology fluctuates over time with how competitive or uncompetitive it is. When I applied for residency in 2000, I was told by my mentors that because I spoke English, I could match anywhere in the country. So I hit the specialty when it was at a lull. I've now seen it undergo rises and falls in its competitiveness, and it has gotten competitive once again today. I think that there are incredible opportunities, despite how competitive it is to get into the residency. There's still a paucity of folks that would tell you they want to become clinician scientists in anesthesiology. We do have spectacular candidates, but I would say there's certainly room for more. I don't know how the others feel about that.
Yeah, I would just echo what Max just referred to in the context of physician scientists. There are not an overwhelming number of applicants that are saturating the physician scientist pathways. I think the categorical residencies are very competitive, but I think those that are applying to programs that are seeking to train physician scientists, you will have a leg up if you've had a sincere research interest, particularly if it's been bolstered by previous research activities. Doesn't mean you need a PhD, but some evidence that you've had some scholarly work, ideally with a publication. I see there's a question in the Q&A box about how to position oneself for one of these research paths if your MD PhD research has not been specifically in the field of anesthesiology. I think Mark said it best. It's hard to imagine something that's not a fit for research in anesthesiology. We do research across every organ system, all extremes of life, from basic to clinical to epidemiology, outcomes research, in perioperative settings, in the ICU, in the pain clinic. So it's really hard for. I once had a chairman who said one of the great things about research in anesthesiology is you have an excuse to study just about anything. And I think there's a fair amount of truth to that. I can speak for our program. We in no way limit ourselves to people that have had specifically research in anesthesiology. So our applicants come with very diverse backgrounds in the type of research they've done, whether it's clinical or basic science. And the real goal is not so much what you've done before, but finding a passion to go forward and finding the right environment and mentor to allow that to happen. So I would in no way worry about being, pigeonholed into a very specific area of research to pursue research in anesthesiology. Like I said, I'm studying asthma. The guy down the hall is studying kidney ischemia reperfusion. Across the way, he's into purine metabolism and sepsis. So even within a single department, you'll see a lot of diversity.
I'm happy to tack on there a little bit too. I mean, I think some of the competition within the residency is there's an incredible national demand for anesthesia and sedation, as far as everybody wants to do procedures, lots of patients need surgeries. And so that's driving a huge interest across the country in procuring anesthesia services. So that also, just through simple supply and demand economics, means that anesthesiologists are well compensated and can really take their trade all over the place. You're not locked in with a specific patient population that you may have established. Now, there's some pluses and minuses with that. I mean, frankly, I found that attractive at the time when I was coming through. At this stage, I kind of like, it would be kind of nice if I knew some of my patients coming through the door on a daily basis and was able to build some relationships over time within the community, within the patient population. So I think as long as that demand remains very high, and I think it will remain high unless there are some really paradigm shifting changes in the way that anesthetics are provided and who is providing them and in what sort of oversight fashion. And as long as that's the case, I think the demand at the level of the residency will be high. I think the times that Dr. Kelz, that Max was talking about previously, there was a thought, oh, it's obsolete, it's going, and I don't really know why that was the opinion, but the thought was there will not be jobs at the end of the tunnel, which was, clearly wrong. I also echo that we want in the field, and the field needs candidates and that want to do research. And so because of that, the strongest departments very much value candidates that do want to do research, and they will receive favoritism, and they will receive special opportunities. And coupled with that are typically clinical departments that are very strong financially and structurally within the institution, because we provide the engine for financial gain for the institutions, which is usually through a lot of procedural care. And that's just the reality within the US. So with that, if you want to do science and you have a leadership structure within your institution that is also eager to promote science, there is an incredible opportunity for conducting research and for having a path to advance through the years. Some of the most popular or successful mentorship paradigms that I see, or sometimes I try to set up, are with a mentee who is bringing some sort of expertise outside of anesthesiology into the perioperative space. So and this has been alluded to by several of the panelists here tonight. So for example, a cardiologist who is a vascular biologist with an incredibly rich understanding of how to study the vasculature and its role within perfusion, inflammation, coagulation. Okay, what's a great patient population to look at that? How about, people bleeding, being transfused, inflamed, in the perioperative space? So bringing that level of or a very high level of biological expertise within the perioperative period and the patient access and the models that mimic critical illness is a really strong combination. And so when I introduce myself, say I'm out at a baseball game or something, say, "Oh, what do you do?" I say, "Well, I'm an anesthesiologist. I do research." People think I'm researching anesthetics. That couldn't be as far from the truth. You really have the opportunity to kind of look anywhere. I mean, another example is a different cardiologist, mentor of one of the mentees in our research group, is an expert in lipoprotein communication and HDL as a vehicle for paracrine signaling and having cargo of various different proteins that are important in, cellular function, cellular trafficking, cellular behavior, and then looking within a perioperative space for how does that science apply there. And so having kind of an anesthesiologist and additional high-end biologist mentoring a mentee in that setting has been very fruitful and successful too from a funding perspective.
There's so many great questions in the Q&A box. I don't know how we're going to get to all of them.
Where's the box?
Deborah, did you want to prompt us on which questions we should address, or?
Yeah, there's quite a few in the question and answer. We'll try and get to these as well. We have some that were submitted ahead of time by folks, so I do want to give a nod to that. There's no way we're going to answer everyone's question here tonight, but one of the common themes of some of these questions is, and you guys have already touched on this fact, is that the anesthesiologist space right now is very competitive, but the physician scientist tracks are not fully saturated. So, to some degree, and APSA is always interested in this, it's like, what is attracting physician scientist trainees to certain spaces and certain clinical specialties and not to others? And I think, there are certainly people that have a science background, whether it be PhD or master's or whatnot, that end up being in categorical programs. So I guess from your point of view, if someone were on the fence, could you speak a little bit about the different structures of PSDPs, how one might decide to go towards a research track versus a non-research track? What are the opportunities, with those different paths, and how does one make that decision for our audience members here?
Well, I'll take a first crack at that. So embedded in some of those similar questions is the MD versus the MD PhD and sort of their competitiveness and how to best prepare for these research tracks. And I just want to say that I don't have that many letters after my name as some of my esteemed colleagues on the panel. And I think with the right motivation, environment, and mentoring, I think even without the PhD degree, people can be successful physician scientists. I would say that the pathway to prepare for that is largely by getting involved early, being engaged, and I can't emphasize enough choosing the right mentor, which is a little bit of the secret sauce of not necessarily knowing exactly how to find that person, but someone who's been a successful mentor in the past is probably a good start. I'd encourage everybody to reach out to current program directors. So for example, at Columbia, we bring in usually 2 research track residents per year. However, every year we have numerous people that come in through the categorical pathway that we are more than delighted to support and mentor and develop as well. So I often say that our Apgar Scholars 2 positions are sort of the minimum number of residents that we hope to attract every year. But most programs that have engaged and motivated residents are not going to turn away that enthusiasm, whether you come in through one of these formalized research tracks or not. Some of the research tracks ask for certain commitments of time beyond residency, and in exchange for that, some of them give a little extra salary during training and so forth. So those types of programs, which we do request a little bit more commitment to stay in your training beyond residency. And if that scares you, and it probably does, because you're not only talking about 4 years, but maybe a clinical fellowship in 5 years, and then maybe time beyond that. And that sounds like a long way in the future. I would say that most of the programs represented in these PSDP pathways are going to be embrace your interest in being a physician scientist, whether you come in through this formalized track or not. And I can tell you that some of our most successful physician scientists at Columbia were never in the Apgar Scholars track. They came in through the residency, got caught by the bug, got well mentored, and are now, NIH funded independent researchers as well. So there's no single path to have a career. And I would just say that it's more important the environment you're in and being in a department that's going to be able to support you and your mentor through these training periods and career paths.
If I could tack on to that, so at Penn we have the DRIPS Scholars Program, which is, I've got to give Margaret Wood all the credit. She was the one, I think, that came up with the Apgar program at Columbia, and most of the other departments around the country have done some variant of that. We also try to have 2 spots. We have one now that's a dedicated pre-match spot. To be competitive for that, individuals don't have to have a PhD, but we do like to see at least 2 years of research time. And I always say that's because we want to know that the applicant will have the drive to love science, not only when it's working, but also when it gets tough and things don't work as you expect. And that more than anything is why we say we want to see 2 years, because most of us aren't lucky enough to be doing science continuously for 2 years and have everything work. But we have a second arm into the DRIPS Scholars Program that is from within the residency. So similar to what Chaz just said for categorical residents. We've never had a resident in our program in the 15 years or so that we've had the physician scientist training program, the research and residency program, who wanted to be part of the DRIPS and wasn't able to do it.
you. The next question is from our chat. Would you be able to speak more on what medical students who are pure MDs without the PhD component can do to become competitive physician scientists in anesthesiology? And maybe Dr. Bicket can speak on this.
Yeah, I'm happy to. I mean, I certainly came through kind of more the, MD focused programs, and similar to the programs you've heard before, our C-STAR program at the University of Michigan typically is a decision that is made by residents, once they've come here and after they've matched and kind of gotten their feet wet a little bit into the specialty. Some programs you've heard take it where there's like a dedicated track, you got to know ahead of time to do that. And so those are opportunities. But within most of these major academic departments that you're seeing that have T32 programs, that have hosted MRTG fellows, that have a cohort of individuals who are on K grants or who have robust externally funded programs, these are going to be environments where the mentoring in particular is going to be there for that to happen. And really all it takes is kind of a little bit of putting a call out, whether you're working with someone clinically, engaging with them through that program. If you're a medical student and happen to have a rotation in anesthesiology and on the pain side of things, or reach out as well. And so certainly, I'm at the University of Michigan, and several of the medical students I've worked with have shown interest in some of these summer programs or reached out about potential projects. There are times where I've worked with individuals in the pain clinic or in the OR, and we've had some interesting cases come up that actually have raised some questions and then wanted to work on some projects together after that. I think these opportunities to interact shouldn't necessarily be taken for granted and offer a nice entryway depending on where you're at, and trying to gauge a little bit about that fit and how the track records have gone on both sides. Maybe something to think about when trying to figure out where's that right match, right? The specialty, I think, again, offers a very broad array of options, and some of it may just be trying to find that right match. One of the questions in the chat I thought was interesting was about, kind of like what skills may equip someone best for that. And I mean, the answer, it's really hard to give a great precise answer to that, because it really matters about kind of, as opposed to the skills someone has. Yeah, I think it's a lot about, like, what's the question we're trying to answer and how we're going about doing that. And Chad spoke about this engagement piece for it. Really, from my sense, I'm always fascinated, like, to what degree of the ownership is there? What have you done in the past, and to what degree, have you made contributions, and then understand really why we're trying to do some of these aspects. And the ability to speak to those things, right, makes a huge difference, I think, in elevating the conversations and help demonstrating your past experiences and how that helps. And I think that's just across any stage. It's not necessarily just for medical students or residents, but even, I found as an early career faculty member trying to get into the more clinician-scientist work or into the more of the scientific community, that those things really made a difference. So it's certainly never too late to start. And again, I think it's hard for me to think of a different field that offers as many opportunities across the research spectrum, both basic science, but clinical, translational, policy-oriented ones as well, which I've certainly really enjoyed so far in my career.
I think the other population of folks that we clearly have on the call, based on some of the comments in the chat and the pre-submitted questions, are later on in their training and would like to hear about, trying to make the jump to independence and gearing up for things like K awards. Can you guys kind of speak to that? And I think also, in the same vein with what's going on nationally with the funding situation, it might be interesting to hear your perspective on how the current landscape is going to affect future anesthesiologist-scientists. I know that's a lot to tackle, but I think we have the right people on the call for it.
I think, and I was going to, I'm debating about using the word. I was going to say an anesthesiology, department crutch is a strength. In that, as I alluded to before, having that financial strength to support scientists and science during challenging times relative to federal program, assaults on science and also funding mechanisms is a strength rather than a weakness as compared to other fields.
I'll pick up a little bit about the other part of that question about sort of pathway into early career. We've talked a lot about T32s because they're a very popular way of supporting people, usually for a 2-year period, some as long as 3 years with at Columbia and most places, that's usually in the earliest faculty years that you can be on the T32. I would say the general pathway to eventual independence is, while being supported and mentored on a T32, to start looking for the next extramural, meaning outside of your own institution. We're fortunate that FAER is one of those, is the flagship organization that offers the MRTG, which is like a mini K award. It's a 2-year award, similar budget. The grant, not by accident, has the same sort of sections that a K award has: a mentoring section, a career development plan, a good science section, intentionally designed that way so that FAER is hopefully a stepping stone to an NIH grant. And that's most commonly a K23 or a K08. The magic of those grants is they continue to protect a lot of your time to continue to develop your research program, ultimately towards what's considered the first independent award, which is usually an R01 and so forth. Some people skip the steps. Some people are overachievers compared to my path and have skipped over Ks and gone right to Rs. In fact, Dr. Billings mentioned H.T. Lee, who came out of a clinical fellowship with an R01 in hand. So those are unusual individuals. But I would say that the normal sequence is starting out with protected research time, which might be on a T32, further extended and supported by a foundation grant, and then one, hopefully, to a K award and beyond. As far as the funding landscape, it's unknown at this point. I think everybody obviously has concerns about what the overall NIH budget is going to look like. Many of our institutions are encouraging us to look for other non-federal funding from philanthropy and foundations and so forth, and that's certainly part of it. I will say, you might have read about Columbia a little bit in the news in the last few months and grant funding and so forth. The institution has very quickly stepped up to fill holes and is backfilling a lot of funding that might have been interrupted to keep research programs going while we navigate the current landscape and so forth. So it's hard to say exactly what the federal funding is going to look like in next year, let alone multiple years ahead. I think what Dr. Billings said about being in a strong department that's committed to research, that will find the resources, usually from clinical revenue, to help foster physician scientists, is the way people are going to thrive in the specialty.
If I could just tack on a little bit, clinically, when I'm seeing patients, I'll say if there's an advantage to gray hair in anesthesiology, it's that the risk of nausea and vomiting goes down. On the research side, if there's an advantage to gray hair, it's that we've seen peaks and troughs in funding cycles. So when I was a graduate student in the 90s, NIH pay lines were in the single digits. I remember postdocs, junior faculty, everyone saying science is a terrible career, you'll never get funded. And shortly thereafter, we went through the doubling of the NIH budget. There's another trough in funding in the 2000s. And if you can take a longer timeline view of funding by the US in science, it does fluctuate. This time feels different. I wouldn't be telling the truth if I said otherwise. But the advantage of something like an MRTG which is affectionately called by some the pre-K program or a K-series grant, is that you're really one grant away from being in a different funding climate. And I actually think it's a great time to be heading into residency and thinking about that career launch, because by the time you finish and you're coming out looking for that foundation or federal funding, I expect it'll be a different financial climate, different funding climate.
Our next question kind of follows up on that topic. And I'm going to expand on the question in the chat a little bit, but what kind of accomplishments or milestones for each stage of training should trainees be to reach to be competitive for grants at each stage? So medical students, residents, fellows, earlier.
Cynthia, I don't know if others heard you clearly. You were breaking up a little bit. You mind repeating?
Oh, I'm sorry. Yes. As a follow-up to that recent question, what kind of accomplishment milestones should trainees be trying to reach to be competitive for grants at each stage? So for medical students, residents, fellows, and early career trainees.
If I heard you correctly, I think you were asking basically about metrics to be competitive at each stage of grant applications. I think the answer always begins with publications. Publications are the currency to get future grant funding. Publications are an important metric about success and accomplishments. And very often, as one progresses through different stages of funding, the expectations for an increased number and an increased quality of publications is looked at with increasing scrutiny as one goes through one's career and grants. So I would say, the first simple answer is publications.
Maybe the only other thing I would just couple with that is, if you're thinking about applying for grants, this whole process comes from support of an environment that is, it's kind of the foundational level for the work to be done. And, this work happens within different systems, whether you're in a medical school or residency program or a faculty position. And I think one thing just to be aware of is, anytime challenges come up in the clinical sphere, things in the research sphere certainly don't become easier, right? So if you're a medical student and, it's a challenge in terms of, the kind of basics and rotations, it's not saying you have to excel in everything, but that certainly can impact the ability to achieve milestones when it comes to grant applications. My sense that everyone who's on this call right now, by virtue of being interested as a clinician scientist, is like I said, head and shoulders above where I was as a medical student and resident in these other areas. So it probably needs to go without saying, but I think the couple to that is like an answer to a previous question, which was someone was asking about, ways to, what skill set do you really have? And I think, this ability to just kind of differentiate yourself into really anything you want to do really goes quite a far way within the specialty as well. Excellence in those clinical rotations, I think, helps drive better questions, informs approaches, whether you're on the basic science or the clinical side of things. And really, it's a very nice complementary relationship to the two, which is one of the reasons that it's so important to have clinician scientists out there, regardless of what we're focusing on.
One of the other things I think you guys have, touched on about a strong aspect of being in anesthesia is the flexibility that comes with the career. There's been a couple questions in the chat about breakdown of how time is divided in the long run. I was wondering if you guys could give us a little more insight into how flexible is the breakdown in terms of like a classic 80-20 split, and how, your career may have changed over time in those aspects.
So I'll start. I sorry to hog the microphone, but the 80-20 or 75-25 model is usually first generated by some of these early support mechanisms we've talked about. So for example, the T32, the NIH requires you to devote 75% of your time to research. The MRTG requires you to devote 60% of your time to research. And the reason why these numbers were derived is through the experience of many. It is understood that really devoting adequate time in one's early career to developing the skills, the question, knowing how to address a hypothesis, learning how to write and communicate your findings takes time. So it's not, these aren't really arbitrary ratios. They're really meant to protect and give realistic time to develop some of these skills. As one moves on in one's career, the numbers tend to shift a little bit back towards more clinical time. I think many of us are doing maybe 40% clinical and maybe even more than that, because the expectation now is that you've developed some of the skill sets, you've written grants and published papers. It's a little less arduous to get through those sorts of opportunities. Is it possible early on not to do an 80-20 split? It is, and your clinical department will be more than happy to give you more clinical work to do. But it's really sort of a personal protective mechanism to make sure that you're getting the adequate time to develop these necessary skill sets. Are there people that have done, 60% clinical, 75% clinical, and had a successful research career? Absolutely. But I think the deck is stacked in your favor when you have this early protected time early in your career.
The other thing I would point out is that percentages, they're not always the same. So if you look at anesthesiology compared to many other medical specialties, because we're a 24/7, 365 specialty where our physicians are often taking call either in-house or in some call pools, they may be at home, but they're getting pulled back in the middle of the night. Many programs will talk about a percent split that is 80-20 or 75-25, but that doesn't look like a medicine 1 day a week clinic. So for the vast majority of my career, I've either been 20 to 25% clinical, but because at our institution, we participate fully in evening calls or weekend or holiday calls, what that means is I really am doing, a day in 5 or a day in 4, but then I'm doing my fair share of all the off hours work that really nobody wants to do. And so practically what that means is I've never really worked fewer than 20 hours clinically a week, even though that's been described as 80-20, 80% research, 20% clinical. The flip side is I've also never felt overmatched in the OR. I feel like I have enough clinical time that I can put my clinical anesthesia skills up there with just about anyone. And the thing to remember is anesthesiology is a really fun pocket of medicine because we're intervening directly and looking at data continuously. To me, anesthesiology always felt like being in a physiology lab, but we get to apply pharmacology or neuropharmacology for greater good. But we don't have the same checks on us that other specialties do. And so I do think it's important to ensure that that when you are in the ORs or the ICUs or the pain clinic, people don't say, oh, Kelz must be really good in the lab. Or when I'm in the lab, they might say, oh, Kelz must be really good in the OR. You want to make sure that you're not seen as a weak link in either domain. And that's important and relevant to how we split time in the specialty.
Thank you so much, everyone. to make sure that we end the session on time, we'll start wrapping things up. Unfortunately, we're not able to get to everyone's questions, but please feel free to reach out to our panelists afterwards. Many of them have shared their contact information in the chat, and we're happy to share this in our as well. So for our whole question, I'd like to ask each of our panelists to share any final thoughts and or one final piece of advice for aspiring anesthesiologists.
I would just encourage everybody to go for it. Have your cake and eat it too. And it doesn't even necessarily apply specifically to anesthesiology. I think anesthesiology is incredibly rich in the opportunities that it provides. But you've got one life, and make it exciting and diverse, and have opportunities, and have multiple irons in the fire and balls in the air. And a life through discovery and research provides that. It also can be anchoring as far as keeping you on task with long-term objectives. You don't feel lost in some sort of just churning through patients in a clinic or patients in an OR, or patients in what other sort of environment. I think hopefully we as a group have highlighted some of the strengths or the benefits of a career as a anesthesiologist or perioperative physician scientist or intensivist or pain physician. And I mean, my final thoughts are, to go for it. I think when you look back, I don't meet a lot of people that regret having developed and pushed in a career as a physician scientist. And you were speaking of the choir a little bit. I mean, this is APSA here. So you're already drinking the Kool-Aid to an extent, but drink it for another 20 years and I think you'll be thrilled.
Does anyone else have final words for us?
Yeah, I'll just share. I think research feels like a hobby, and if you can have a career doing your hobby, you'll never work a day in your life. There's some famous quote around that sort of idea. As I look back, I can't. I'm so gifted to have sort of stumbled upon the people in my life who have sort of mentored me, and I think we're all a victim of those who we meet and are guided by throughout life. So I keep coming back to the idea of mentorship because I think it's just so crucial, not only for your success but for your inspiration to pursue those goals and so forth. And one final thought we haven't really touched on too much is sort of the life balance that a physician scientist in anesthesiology has. It was great. I was able to coach Little League baseball for my 3 little boys growing up because I had that flexibility in my career. You might work Saturday night, but at least you could coach baseball Saturday morning. So there's a lot of advantages to this specialty with regards to raising a family and having a family life. And I think that's not always true in some of the other, particularly some of the other procedural specialties, where when we're not on call or we're not assigned, nobody's calling us or interrupting our research or our family life and so forth. So I just wanted to highlight that I think that's another advantage of the specialty. And if you're doing research within the specialty and have more control over your time, it really adds to that family life and that life balance.
Yeah, I think my closing thoughts, again, really appreciate the invitation to be here and the perspective from, I certainly learned something from all the panelists today, which is great. Anesthesia, the specialty, has a deep history. There are currents there that are often somewhat surprising to learn about. Pulse oximetry came in just the 80s. Like my dad was practicing when this happened, and he remembers telling me about the newfound thing that they put on people's fingertips that tell them how much oxygen saturation people have. I mean, that's an amazing invention for safety in the United States and the world around, right? When it comes to operative care. And that's just part of the history of the specialty. The question is kind of, what's going to be our generation's version of that? And I do believe that clinician scientists are going to be at the forefront there. for people who haven't already differentiated or are really thinking about that, consider, I had no idea when I was coming through that, non-basic science fields could be part of PhD training that eventually leads us eventual clinician-scientist careers. It doesn't necessarily have to be in a public health domain, but I've worked with people with PhDs in economics who are MDs and other things of that nature. So there's a number of options out there. They can all fit within careers with anesthesiology, and it's a wonderful specialty to consider if it's hitting these high marks for you. And certainly the specialty would benefit from your involvement. So thank you.
Well, I'll put in a blasphemous close, which is if research feels like a hobby, I'll say clinical work oftentimes feels like a vacation in that, I get to show up in the OR. I don't have to worry about, is my clinic full or not? Patients are there. In anesthesiology, we get a skill set that's truly meaningful. I always used to wonder about the nerve of a firefighter to rush into a burning building. And I never thought I would have that steely resolve. Residency training pretty much bronzed me. So when patients are coding or they're on death's door, it's the anesthesiologist running to figure out what is it that are the true necessities for life. And that's a skill set we get clinically. And then very meaningfully, we're able to intervene in ways that really feels like we're magicians. And the more pharmacology we know, the deeper our top hat. We can pull drugs out for scenarios that seem odd. I think back to doing cerebral aneurysm cases that rupture. And of course, the solution to buy this neurosurgeon more time is you stop the heart. So we'll push a huge dose of adenosine. And who would think to do that? So clinically, the specialty is just full of amazing possibilities. I could go on and on about what it takes to do an awake craniotomy and knock out pain, return consciousness and have a patient cooperate while the neurosurgeon's operating on their head. There's just, clinically, it's a fascinating field. It's really, in my mind, applied clinical neuroscience. So for all the folks that put in the neuroscience related questions, I never dreamed of becoming an anesthesiologist, but have been thrilled that I made that choice. And I'll say one last thing about research is that we have phenomenal questions that you just need to spend a little bit of time thinking about. And I am still very bullish on the opportunity that this specialty affords for clinician scientists. Whether you decide to be an 80% research or 80% clinical type person, I think it's a wonderful field, and I wish more medical students knew about it.
Well, this has been a just fantastic panel. We're very, very lucky to have all you guys in one virtual room. So we want to thank all the panelists for their time and also FAER for collaborating with us. If you've enjoyed our talk tonight and the topics, we would love to, have the folks on this call more involved in the APSA community, including the residents and fellows organization. Definitely copy down while you can, while the Zoom call is still going, the links that Dr. Kelz and the FAER team have provided in the chat. And then we also, have several folks on the APSA side here in the background that have done tremendous work, advertising tonight's session. So we do want to acknowledge their volunteering here and thank them for their time. And we have 2 QR codes here. If you are interested in getting involved in APSA, we would love to have you in the community, either as a national leader or a general body member. And I just want to close again by saying thank you so much to our panelists and the entire team here tonight.
Thank you.
Thanks for having us.
Yeah, thank you very much.
Thank you for the invitation. Have a great night.